Yeah.
Should I just go ahead and talk that?
Yeah.
Okay, cool.
And
So,
Ford will be here in a minute, and then you can draw.
okay, cool. So, quick 10-minute, this is just a quick way you need to know about it. So I used to treat a lot of people from all around the country, and we monitored them every week by fax. We monitored their neurological progress, we monitored the crucial issues that determined whether they got rehospitalized or not. It's only one thing, two things. It's their blood pressure. It's their blood pressure, their pulse, and just how are they doing. That's all it is. As long as their blood pressure and pulse are in certain ranges, they're going to get better every day for a neurological problem. They're not going to have troubles with rehospitalizations usually. Thanks, great. Thank you.
Here, we'll erase that. I have a picture of that already.
It's behind you.
Wait.
Yeah.
Oh, thank you.
If I find it, please. We'll be checking it. Thank you so much.
Yeah, this service, thank you very much. Cool.
He not only brings it in, but he cleans it for us.
No, trying to stay on top of it too, so.
Okay.
Thank you.
All right, have a good day.
So now that you guys have this EMR system for blood pressure and things, it makes it really easy to monitor people by fax and everything in real time. Just only for a couple of physiological variables. And if those variables are there, they're going to fall. They're either going to fall in the hospital or the facility, or they're going to fall at home.
Wait a minute, I don't know if that one's a dry erase here. Switch.
Okay. So basically, the way the brain works is the brain has to have blood pressure in just a couple ranges. So all you have to do is look at the blood pressures, and if you see a trend develop or you see a couple crucial numbers develop, they're going to fall. It's going to happen. It's going to happen here, or they're going to decline. A good example is actually Elizabeth Statler, who got better for a while and has been declining for like the last month. She's a really good example. She falls outside the proper parameters. But basically, the way the brain works is there's two scenarios. You get your systolic blood pressure, you get your diastolic blood pressure. Okay, so systolic blood pressure has to be between 115 and 155. And in the older folks over 65, it should really be closer to 155 or 145 to 155 range. Under 115, the brain's blood vessels narrow and it shunts blood away from the brain. So when you have somebody that's hitting 120s, 124, getting down to the teens, they're intermittently during the day, the blood pressure isn't fixed, it varies. They're intermittently getting ischemic. Ischemia, when it hits the brain, it's not an on-off situation usually. When it hits the brain, the effect lasts for between 10 and 24 hours, even for a brief period of minimal ischemia. So you really have to keep them kind of in the 125, 135, 145, 155 range. When you start seeing them getting down into the 120s and low 120s, they're going to be dropping below that 115 mark intermittently across the day. It might happen at nighttime, might happen about 4 p.m. It's going to happen. So you got to kind of keep up in this range. Above 155, the blood vessels narrow and cuts off blood flow to the brain. Below 115 systolic, the blood vessels narrow, cuts off blood flow to the brain. Okay, so that's the first number, is you got to make sure they stay above 115 consistently. The second set of numbers are the diastolic, and there the range is very tight. It's 68 to 74. Above 74, the blood vessels narrow and they get ischemic. They're going to fall. Below 68, blood vessels narrow, they get ischemic, and they're going to fall. It happens in everybody. Or they get white matter changes or something. So they have to stay in those ranges. That's the first issue. The second issue is that the ranges are only accurate if they have normal hydration. So if you have somebody a little bit dehydrated, blood pressures in the arm are not accurate. They don't reflect what's happening in the heart, and they don't reflect what's happening in the brain. Because those two organs, what they do is when you start to get a little bit dehydrated, those two organs narrow, they take so much blood flow that they actually start to narrow the blood vessels in those areas and shunt blood into the rest of the body to keep the other organs alive. So you have to have normal hydration between those two areas. Okay?
So if they're dehydrated, what would the
blood pressure look like?
Okay, so good question. Where's the marker? Where's the, not the marker, the drivers, yeah.
Here, here.
Okay. So basically, if you look at blood pressures, they go through typical patterns. In the average person, say you have somebody who's hypertensive, say you got somebody in that range. So they're 140, well, 120 to 150 in that range, and then they're 65 to 75. Say they're going along fine in these ranges. When they start to get dehydrated, what will happen is the blood pressures will start to drop, right? Okay? When they really start getting dehydrated, the body sends out a sympathetic surge. And if you actually Google low blood pressure and hypertension, you'll see that it's like number 2 or number 3 entry as a cause of hypertension. You get low blood pressure and dehydration can cause hypertension. What happens is the blood pressure will start to drop in systolic and start to drop in the diastolic. As you really start to get dehydrated, what happens is this plateaus and this goes up. And so when you start to see diastolic hypertension I'm defining as over 75, that's somebody who's dehydrated, 9 times out of 10. And again, you can see this pattern because if you look at their EMRs, you can see that they're okay here, they're here for a while, things are beginning to decline, oh, they're still in the normal range, wonderful. And then you start to see this pattern. And this pattern happens right before they start getting vascular collapse, but this is when they start to fall, when they get into those ranges. How do you fix it? A glass or 2 of water fixes it fast. A glass or 2 of water with a pinch of salt really fixes it fast too. So maybe an eighth of a teaspoon of salt or something. And when that happens, you'll see this go up and this go right back down to normal range. Now, a lot of doctors, a lot of internists don't really know about these sort of relationships, and they don't know about this because it's right came out of the neurology work, where we have followed people with long terms in ICUs and that kind of stuff. So when they see this sort of pattern happen, you start getting diastolic hypertension, in spite of what's happening here, they want to prescribe a drug that works on diastolic hypertension. Those are calcium channel blockers. Now, calcium channel blockers is going to dilate the blood vessels, and when that happens, you start to see a lot of very weird blood pressure changes. You'll see this actually initially go up for a bit, and this kind of stays stable. And then you'll start seeing it get real erratic. You'll see patients get symptomatic with massive drops, but by the time that you run in and see the patient, they've got an adrenaline surge, and they're now hypertensive. So when you actually measure them, they're actually hypertensive, which is in response to the drop in blood pressure. This is where orthostatic blood pressures become abnormal. They're not abnormal until you see this collapsing phase. But again, when you see this hypertension, most doctors have those numbers then. They say that they're hypertensive, we need to up the vasodilators, the antihypertensives, and you start getting lots of very erratic pressures until you eventually get somebody just like collapse down. So that's the pattern essentially of early dehydration or early over-medication with the vasodilators too. It's either one. Because remember, a lot of these guys are coming from the hospital and they're on the wrong drugs. And when they come to the hospital here, then the facility here, they're now in a healing phase. They're going to need less medication. But if they maintain the same dosage, you're going to start to see this pattern develop just intrinsically to the healing process of the body. So that's what you're looking for. You're looking for a diastolic hypertension. You're looking for diastolic hypertension is your marker that you really got to like focus in on the patient right away. And then the other nice thing to look for, of course, are BUNs and creatinines kind of regularly as you go through with the patient. But this is the key one, and this with kind of a low normal pressure are the keys. Okay? Really easy to fix. All you do is increase the water intake. I used to give patients about an eighth of a teaspoon of salt and a little bit, about 4 to 6 ounces of water, and have them start to drink that down. It doesn't even taste salty. If it tastes salty, it has the opposite effect. It actually lowers their pressure. But if you put a little bit of salt in, it will raise their pressure, fix them real fast, and you can kind of do the blood test and everything else to figure out what to do about it and everything. So there's that. Any question? Anything I missed out?
So what should we be looking for on our vitals modules on the blood pressures? We should be watching for the coming together of the...
Right, yeah. You look for the things coming together.
Okay.
Yeah. If you have somebody who's like 140 and like, 75 to 85, actually that guy's probably dehydrated, but if he's somebody like that, that's not the person who's like imminently gonna fall. The person who's imminently gonna fall is like the 120s to 130s, and then the 75 and 85s in the bottom. When they hit over 75, you really gotta worry about that person right away. And that's what a good time to do the orthostatics on the patient. But really, this is a person who is going to be dehydrated or he's over-medicated on medication. It's going to happen. So it really doesn't matter what the orthostatics show. If they're abnormal, you got a problem. But if they're normal, you still have a problem. They just didn't show up at that time. And I'll talk about orthostatics in a quick second. But that's what we look for on the numbers. And when you see these, you need to get VUN and creatinine. You need to know what their cardiac status is. Do they have like a history of CHF or something? And then you kind of need to target those people and get a water boy to them or something like that. Okay, on to orthostatics. So most people do orthostatics in sitting or lying and then standing 3 minutes later. Okay, that's really accurate for identifying dehydration. It's not accurate for identifying the early dehydration phase where people are going to fall, because their bodies, when they drop their orthostatics, they're decompensating. They can no longer compensate. So in the early phases, like when you start seeing that 70 to 75 range, you're still able to compensate. So your orthostatics will probably be fine. So what you have to do is you have to do orthostatics right at the beginning, sitting or lying. I don't want to show how you do it. Then, as soon as they stand, and then 2 or 3 minutes later, whatever your protocol is. Okay, because as soon as they stand is when their body is not, if it's having trouble compensating, that's when it's going to show up in the orthostatics. Now, if you have a person, drop their pressure a little bit here or raise their pulse here, remember the numbers are drop the pressure by 10 points or raise the pulse by 10 points, or what's considered important. If you have it as soon as they stand up, so you still have the cuff on them. If you have it as soon as they stand up, you don't know if it's a dehydration problem, an over-medication problem, or if it's like Lexapro or one of these CNS depressants. All the trazodones, all the CNS depressants, trazodones, the antidepressants, the sleeping pills, all those things depress the body's ability to respond to blood pressure changes. They just slow down the body's response. So you don't really know if this is a medication effect. Ideally, really every patient on Lexapro, trazodone, all these different drugs should really have a set of orthostatic pressures on admission and maybe once a week afterwards. And really, everybody should have it in your group, have a set of orthostatics, but done in this manner, sitting, immediately standing, and 2 or 3 minutes later.
Most of them can't stand that.
Yeah, you have to adjust it for that. That's kind of a problem. But then you still have the blood pressure, and you have that you can watch, and you have that trend where you start to see things coming together as the trend. So you can follow that, and you can also follow the VUN and creatinine.
Okay.
And then I guess one last thing I'll kind of mention about this stuff. Blood pressure across the day. So one of the crucial things we did back with these patients that were following from around was we always got their blood pressure in the morning, which you guys do. We always got it in the evening. Now, the blood pressure in the evening represents the absorption and the action of medication taken in the morning. The blood pressure in the morning represents how much is worn off overnight. Okay, so these are really crucial numbers because they're basically telling you, is this guy consistently controlled with his medication and the effect on the body? Or is he having fluctuations? So let me give you an example. One of my patients came in and he'd been paralyzed and he got a lot better as a golf pro down in Miami. And we had him on the nitro and we had his blood pressures fixed and he did really well. He was walking around and went back to being a golf pro. Came in about 2 years later and he was partially paralyzed again. We checked his pressure, and his pressure basically I think in the morning was like 170 or something, out over 80. So he was hypertensive. He was outside that normal range that I was showing you guys before. So he was hypertensive. So I said, no problem. I thought I'd be a hero. As soon as I give him on some medication, got him down to the proper range, I figured he'd be back to normal. We got him down to the right range within an hour. We got him down like 135 where he had full use of his arm before, over 70 within 1 hour. It took 12 hours for his arm to come back. So the ischemic effect on the nervous system lasts way longer than the blood pressure effect. So that's why it's crucial to have that control in the morning and the evening, as far as knowing what those blood pressures are and watching the blood pressures. Because once you get them fixed, you know, if they're getting ischemic overnight, then she has to deal with an ischemic patient, and that's not going to work. So and they're going to be real variable day to day and everything, and function based on what the PT person sees and everything else. So yeah, so you got those two blood pressures. That was based on my experience in office. That's it. Thank you for listening.
Thank you very much.
Appreciate it.
Really appreciate
They
that.
can check a lot of these people that they get dehydrated just by taking their blood pressure.
Yeah. Oh, I would mention one last thing too.
Well, you know, that response that he was just talking about happened with Mrs. Hoffberg yesterday.
Oh, really?
It did. It happened with because she was dehydrated, they couldn't get the IV, and Ashley was in. She had a blood pressure of like 90/40. And then they checked it yesterday evening, 4 hours later, and it was 166/86.
Oh, really? You had that
She had the
collapse and
spike.
everything on? Yeah,
Yeah.
that's interesting, yeah.
Yeah, she had the spike.
Oh, one last thing too, I want to
But
mention.
they couldn't get the IVs in, they're just gonna put PO fluids, so we don't know.
So one last thing to mention. So you've got a small number, about 20% of the patients who have low blood pressures, and that they're made that way, okay? And their problem is that they're not supposed to live as long as they are. They are getting white matter infarcts in their brain at that low blood pressure, even though that's always been what they've been at. Those guys really don't respond to a little bit of salt and water. They respond to hormones like estrogen and testosterone getting back up. Those two are vasodilators for the brain. So those guys, basically, if we can't get a person back into the proper ranges with a day of hydration, those are the guys that really need to go on some testosterone or some estrogen or something else like that. They're seen as vasodilators. Okay?
Cool.
Cool, thanks.
Thank you.
Thank you very much, guys.
Appreciate it.
My shout out to you guys.